Our next talk will be Dr. Chavez. She's talking about chiasmal and parasellar disease special considerations.
Okay. Well, going back to 1946, a very smart doctor by the name of Falconer said, the lesson that this teaches us is that every patient with failing vision, i.e. blurred vision, for which no adequate cause can be found on a general eye exam, should have his visual fields carefully tested. And I can't tell you just how important that is, because you really do get surprises. This was a patient that is from one of the textbooks, and it shows a patient with an early bitemporal visual field defect that neatly respects the vertical meridian in each eye. Well, this was picked up by his physicians. A pituitary adenoma was diagnosed, and the patient was offered surgery, which he refused. So he came back in sometime later with a greater visual field defect that was again bitemporal and again exactly respecting the vertical meridian. At this point in time, the patient said, "Okay, I'll have my surgery," and had very good resolution of his visual fields after a transfenoidal hypophysectomy. And I'm going to go back to this in a moment, but I want to first talk a little bit about the anatomy, because as we look at these visual fields, what we want to be able to do is very nicely figure out what's going on and characterize these visual fields as well. And so what I've drawn here is the optic nerve coming to the chiasm and the nasal decussating fibers on one side and lateral one cross fibers on the other side. And certainly down here below the chiasm is the pituitary, and above is anything else that happens to be around the chiasm, blood vessels, meningiomas, whatever else. And so these inferior axons that are decussating here at the chiasm, when they are compressed by an expanding pituitary adenoma, produce a visual field defect, if these are inferior axons and nasal, exactly opposite in space from the retral quadrants that are affected. So you would expect this inferior nasal compression to give superior bitemporal visual field defects. And so again, if you have something growing up here, like an aneurysm or meningioma or craniopharyngioma, and it's compressing superiorly, and it's getting the superior nasal decussating axons that are going to end up superior nasal here in the retina, then you would expect them to be projected into inferior bitemporal visual field defects. And so that helps tell you the direction of the chiasmal compression and gives you an idea about pathophysiology before you do your imaging. Well, I'm going to go back to this one more time and tell you about a patient that we had rescued out of our glaucoma anterior segment clinic. The lights up a little bit, please. And this patient had a visual field defect that was superior, that was bitemporal, but not quite so neatly seen, but it certainly did have a bitemporal quality to it. An older gentleman, not a lot of dermatochalasis, and it was kind of written off as lids. And the point I would make to you is that when you see visual field defects like this, be suspicious for chiasmal compression. And even if you don't want to do an MRI right away, what I always do is a 10-2 red, because I want to see the central axons really well. And I want to see if there's a central depression to red that respects the vertical. Now here's a patient with active compression of the visual pathways and at the chiasm. And here's a temporal defect to red in the 10-degree field that started to extend over into the nasal visual field. And this is when the patient had active compression. And this is a patient after surgery, and here we have some temporal quality to it, but so the central vision has come back. It still respects the vertical a little bit above and below, but it's an improving central visual field defect. So you might say to me, well, why, Dr. Chavez, would you bother to look at a central field? Well, most of what we do that's important is related to our central visual fields. So if you look at the body of axons in the optic nerve and chiasm, its central function is a very major part of this. So if you want to really see whether that funky little lid defect is really real or not, then do a 10-2 red, because color desaturation will be very sensitive. And see if you do, in fact, get a visual field defect that respects the vertical, because that will help you save patients. Well, what else can you see around the chiasm? Well, if we look here, here's the right eye, and there's a temporal visual field defect. And the other eye really doesn't have any appreciable vision. So all we have left is a nasal field. So what do we have here? We have optic nerve on this side, vision's all gone, and we have chiasmal visual field defect on the other. So we have a lesion that's getting the optic nerve in the anterior part of the chiasm, so something at the anterior part of the chiasm. And what about this visual field defect? Well, here's the patient after surgery, and we can still see a temporal visual field defect here that's superior and temporal. And in the other eye, it's more of a temporal island that's come back with a lot of nasal field loss, and that's what we see, don't we, with improving optic nerve problems. We see nasal field loss and little temporal islands start to come back. So this is, again, optic nerve, anterior angle of the chiasm. Well, here's a patient, and let's look at this one. So here we have the right eye, and here's this little visual field defect superiorly, respecting the vertical almost exactly. And then if we look at the other eye, here's a temporal central scotoma, and here's a temporal visual field defect that respects the vertical, and maybe goes over a little bit, but here down below, there's no lid there, and it again respects the vertical. So look for that vertical meridian. This was a patient with a pituitary problem before transsphenoidal surgery, and this is the patient after surgery, still with a little residual temporal visual field defect there. And if you look down here, there's still a temporal central scotoma that respects the vertical. And so, although the grayscale is interesting, the pattern deviation is really very helpful in looking at these visual fields. Well, what tumors are we talking about? Well, I mentioned pituitary adenoma, meningioma. We've all seen these tumors, craniopharyngioma, chordomas, lots of tumors, aneurysms, and vascular lesions as well. So let's talk about a few of these and look at the anatomy. Well, the courtesy of MRI today, they're like anatomical drawings, aren't they? And here's the pituitary and the pituitary stalk going up the hypothalamus. And if we look in here, we can see the pituitary here. Here's the optic nerve chiasm. Here's the pituitary here, the stalk going to the hypothalamus with the optic nerve chiasm here. And again, here we see the anterior angle of the chiasm with the optic nerve. So MRI is very helpful to us in understanding the anatomy. And if we look, and again, here's the sella with the pituitary tissue below, chiasm sitting above, chiasm here, and here's the pituitary stalk with a CSF space around, and in the sella. Well, so that's nice. So that's the anatomy. What about the anatomy is really important clinically? Well, the important thing clinically about the anatomy is that the optic nerve in 80% of people sits about 1.5 centimeters at least above the sella, and so it's well above the surface of the sella and the diaphragma cella. And so in about 80% of people, tumors from the sella have to get really big to get up to the chiasm. So a bitemporal visual field defect is not an early sign of chiasmal compression in 80% of people. And this is a great slide from Walsh and Hoyt, and this talks about the 80% of patients that have the chiasm over the cella. And if we go back one more time, there are patients, though, that have a chiasm that sits right on the diaphragma cella, and that's about 10%. And 5% have a chiasm that sits in front, and 5% a chiasm that sits in back. So what does that mean about visual field defects? Well, what it means is that if your chiasm is sitting right on the diaphragma cella, then that pituitary tumor is going to give you visual field defects very early. And that's why anytime the neurosurgeons see even a microadenoma or a small adenoma in the pituitary, they're sending the patients off to ophthalmology to be evaluated because they want to know, could this be one of those 10% that can have early bitemporal visual field defects from the pituitary because the chiasm is sitting right on the diaphragma cella? Well, what about patients that have a chiasm that sits in front of the diaphragma? So if this is the pituitary, and the chiasm is sitting in front, and this is the tract going over the pituitary, as the tumor grows, it hits the tract. And so you get a homonymous visual field defect. And what if this is the pituitary, and the chiasm is sitting behind? So what's going over the cella are the optic nerves. So instead, you get an optic nerve visual field defect that can be bilateral. So positioning in the patient is really what accounts for some of the visual field defects in pituitary and chiasmal tumors. Needless to say, though, that if we look here at this, we can see on the grayscale a bitemporal visual field defect. But when you look down here at pattern deviation, what you see is that the visual field defect is starting to get sloppy and come over into nasal visual field in each eye. Now, can anybody tell me where is the chiasm being compressed in this patient? Is it being compressed from above, or is it being compressed from below? Because what we have happening is all the axons that are going nasally from each eye have been amputated, and so we have bitemporal visual field defects. So the nasal decussating fibers are gone. So if the nasal decussating fibers are gone, because the chiasm has been pushed either up or down, you really can't tell where the chiasmal compression started from. All you can say is that there's amputation of the nasal decussating fibers. Now, I think realistically anybody could say to me, well, why would that happen? Why should they be most at risk? Well, what you have in each optic nerve in the decussating axons is 500,000 in one optic nerve, 500,000 in the other optic nerve, having to get to the other side of the brain. And so they're getting that way by passing between each other. And so if a pituitary tumor grows from below and it pushes the chiasm up, it amputates the nasal decussating axons. If a meningioma or an aneurysm or a cranial is sitting up here and it presses down on the chiasm, it amputates the nasal decussating fibers. So the lateral, laid-back lateral axons that aren't doing anything, they're just kind of rolling along in the visual pathways, can take the compression a lot longer, and they will be relatively spared, and that's why the nasal field is relatively spared. Well, as luck would have it, there's a little extra blood vessel to the inferior chiasm from the internal carotid that protects the supranasal visual field. So whenever chiasmal compression gets bad enough, the next quadrant to go is infranasal. So chiasmal compression goes, once it's bitemporal, infranasal next. So you can't tell whether the compression's from above or below or whatever. All you know is you need an MRI right away. And so this then is the 10-2 red, and the 10-2 red is lovely. It tells us just so much about the infranasal compression that's going on here and the loss of even the nasal field, more than the white scale does. And we can see how much infranasal visual field loss that patient really has. This was a very nice paper on optic tract lesions by Dr. Savino way back in 1978. And basically what he told us was about the tumors that can cause this, whether they be craniopharyngiomas, aneurysms, pituitary adenomas. And these tumors, if the optic nerve chiasm is prefixed and the tumor goes up, it hits the tract. So you will get tract lesions from pituitary adenomas as well as any other process that can affect the chiasm. Well, this was a patient that we saw who had a homogeneous mass that was intracellular, extended up above the cellar, and a portion of it pushed up. And at this point, what we're looking at here is the third ventricle. And so this tumor is not just supracellular, it's up and posterior. And this patient has a homonymous visual field defect that's quite incongruous, related to the tract compression. And once the tumor was removed, it's still a homonymous visual field defect, but certainly the patient got a little bit of improvement after surgery. All right, well, what else do we need to know about chiasmal processes? Well, what we need to know is that there's a fundus appearance that can help us with that. And that fundus appearance is called bow tie optic atrophy. And I'll tell you, if you don't look for it, you will truly never see it. It's one of those things that you have to really look very, very carefully for. And the only way you'll ever see it, and the pallor goes across the disc, and the only way you'll ever see it is if you look at the inferior disc and then look at the nasal disc and see if the inferior disc is pinker than the nasal disc. And then you look at the temporal disc and do the same thing. You look at the superior disc, look at temporal, and look at nasal and see the same thing. And so bow tie pallor or band pallor means there's a band of pallor going across the midsection of the disc. And why should that happen? Well, if we look at the anatomy of the optic nerve and the fundus, what we know coming from the superior and inferior disc are axons that are destined for temporal retina and nasal visual field, but like our typical glaucoma spots that we check. And coming off the nasal part of the disc are axons that are going to nasal peripheral retina and are going to be accounting for temporal peripheral visual field. And coming off the temporal part of the disc, we're really still in nasal retina, are your 20/20 axons that are going to the macula that are going to be taking care of temporal central visual field. So in a temporal visual field defect, you lose central field here, and you lose peripheral field here, and you get band pallor. Now, I think that this fundus also shows the same thing, and it shows you how subtle it can be. Here's a hyperemic disc here. This disc is still relatively hyperemic inferiorly, but there's pallor in a band, nasal to temporal, and so this patient has a temporal visual field defect. So before you even do the visual fields, you're expecting what you're going to be seeing back in this patient. Does the fundus predict visual outcome? Not really, because if you think about it, what's going on at the chiasm is back in here, and what you're looking at the optic nerve is up in here, and it takes some weeks, if not several months, for whatever is happening here to show up at the optic nerve and for the axons to die back to the retinal ganglion cell. So you can't really predict what your visual outcome will be. And I'm going to just very quickly go over a few things that we can see. Pituitary adenomas, we are very used to seeing. They have a characteristic dumbbell-like shape like this. And the reason is that they're kind of toothpastey-like tumors. And they sit in the diaphragmacella, and they push through the diaphragmacella, and the patient gets a headache when they do. And then they push through, and the patient doesn't get another headache until the tumor obstructs the third ventricle. But they do get visual field changes and visual acuity changes in the meantime. Sometimes as the process of pushing through the diaphragma happens, you can see a little bit of necrosis in the tip of the pituitary adenoma. And we've talked a little bit about the signs, so we can pass that by. And I want to talk a little about some of the hormone-producing pituitary tumors. And one of the Cushing syndrome from hypercorticalism can happen in a small percentage of patients with pituitary tumors. And the point of this is that if the patient looks Cushingoid, it can be from endogenous cortisol, and all the features that we see in this patient, buffalo hump, wound facies, and striae, are typical of what we see with excess exogenous steroids. These patients also get a proximal myopathy, just like with exogenous steroids, osteoporosis, diabetes, and mental changes. So looking at that patient can help you recognize it. Acromegaly is another kind of pituitary hormone-producing tumor, and with prognathism as part of that. Usually these patients are diagnosed very early when the problem is still within the tumor is still within the cella. Supracellular extension is pretty uncommon, and these patients get large spade-like fingers with changes in their ring fingers, their glove size, their hat size, and dental changes that can happen with it, and they can get other soft tissue changes as part of the acromegaly too. And I think the coursing of the features you can see easily in this series of photos of this young man from here to here as part of his acromegaly, and the changes in the hand of an acromegalic patient compared to a normal patient is quite clear. I just love that slide. I think that, and just to remind us that gigantism can happen when these tumors start before the epiphyses have closed, and not only do the vertebrae get enlarged, but all the organs become hypertrophic, and true gigantism can happen. Well, before before we go on too much more, I'm going to talk about a patient who presented with diplopia, and here she actually has a defect in abduction in her left eye. She just happens to be fixing with her paretic eye in this situation, but she has full range of motion to the other side, and her range of motion is full otherwise. So she presented as a 6th nerve palsy, but she was having a lot of headaches. And when we did her MRI, she had a pituitary mass that extended into the cavernous sinus on the other side. And you can see it here and here. If we go back one, in addition to her 6th nerve paresis, it's a little hard with her dermatochalasis to really appreciate the upper lid, but if you look at the lower lid here, the lower lid rides a little higher on the left side than it does on the other. And when you look at her pupils, her left pupil is a little bit smaller, and so we suspected that she might have a Horner's on top of her 6th nerve palsy, and it's for that reason that we especially did her imaging. And so in fact she did have a Horner's on drop testing, and with her 6th nerve palsy related to this local mass infiltrating the cavernous sinus. So the point of that is check pupils in your 6th nerve palsy patients and be sure that you don't have a Horner syndrome, because that in effect complicates your 6th nerve palsy and makes a local tumor at the base of the skull very worrisome. And the Horner's the sympathetic pathway, as you know, starts in the hypothalamus, comes down the brainstem, exits the cervical spinal cord, C8 to T1, and then travels anteriorly in the neck up with the internal carotids to the cavernous sinus and to the eye. And here in the cavernous sinus, it can be compressed by any local tumor from the pituitary or within the cavernous sinus itself. We call this a complicated Rader syndrome as an eponym for the patient, for the doctor who described this some time ago. But the association of Horner's and 6 is important. And I'm going to talk a little bit about craniopharyngioma. Cranios on T1 look pretty discrete and homogeneous. We can see however, on CT sometimes calcification within them, cysts within them, and on T2 you can see increased signal related to cholesterol, protein, teeth, keratin, whatever. So they are multifaceted in their imaging presentation. Cranios can produce bitemporal visual field defects or commonly homonymous visual field defects because they tend to occur more posteriorly in the sella and extend up to the third ventricle a little more quickly. And sometimes these patients will present with disc edema before they get optic atrophy. So disc edema and a bitemporal visual field defect should make you think of a supracellular tumor and perhaps a craniopharyngioma. And meningiomas, I understand, we're seeing a lot in the Arabian Peninsula now, and they can occur along the falx. They can occur supracellar or subfrontal, as this patient with a huge subfrontal meningioma and optic atrophy. So meningiomas really happen anywhere, and their symptoms are related to where they do happen. So subfrontal mentation changes, olfactory groove, Foster-Kennedy syndrome, and lack of smell. And we know Foster-Kennedy syndrome is papilledema in one eye, optic atrophy in the other, related to a tumor and commonly a meningioma, and then along the sphenoid wing as well. And I thought that would be kind of fun to see the sphenoid wing. I mean, we hear about it so much, but we commonly see it as a gray shadow on imaging. And this is the tuberculum cella. Here is the optic canal here, and here's the major sphenoid wing and the inner sphenoid wing coming into the clinoids and to the cellar area. So that's where we're looking, and we call lesions in the inner third, middle third, and then the outer third towards the calvarium. And this is obviously an outer third to middle third to inner third meningioma. The outer wing meningiomas give more blistering of the calvarium and hyperostosis there locally. And This patient I want to tell you about very briefly. And this was a young man who had a craniopharyngioma, and he had his surgery for that. And the morning after his surgery, he started to sneeze. And all of a sudden, he said that his vision, which had been okay the night before, was very decreased and he could hardly see. And this was his fundus appearance, and so although that afternoon had some power to it, the other looked all right, and he had a bitemporal visual field defect when we saw him, but we just didn't happen to know what he had looked like before. But he also had a large central scotoma on that side, and he was 2200, and when we did his imaging, what was clear is that this is his chiasm, and his chiasm is herniated down into his sella. And so one reason for visual field changes and visual acuity changes in patients that are post-op sudden visual field changes is a herniated chiasm into the sella. This imaging was read by neuroradiology as normal at first. So you as a clinician must go back and say to them, no, go back and look better. Something's happening there. And so commonly this can be treated by packing the sella and allowing the chiasm to return back to its normal position. And I'm going to finish there, because I wanted you to be sure that you saw this, because that's really important to think of as a non-tumorous reason to lose vision, and certainly is something that most radiologists will not think about because it's so rare. Most of us have only seen a handful of this in our lifetime, so certainly radiologists see it even less. Thank you.